Okay, we will go ahead and start the program. Good morning and welcome. Thank you for joining us on this rainy, dreary, and icy day. We do appreciate you making that commitment to stick with us. I'm Carla Banks, and this is my first event serving in my new role as chair of United Way of Greater Greensboro's African American Leadership Affinity Group, also known as AAL. At this time, I'd like to recognize our previous chair, Brian James. Thank you, Brian, for your leadership and service over the past year. I'm thrilled to know Brian will continue being very much involved with AAL as a member of our cabinet. Filling my previous role as vice chair is longstanding cabinet member Sharon Dooley. Together, we're looking forward to continuing the transformational impact AAL is having in our community. AAL Affinity Group members are community leaders who are focused on empowering and inspiring communities of color to lead change focused on ending poverty. Together, we represent more than 100 local employers and have helped United Way to raise more than $4 million. With the support of the community, AAL has made a tremendous impact over the years, including hosting our annual conversations with community leaders. This sheds light on our community's most critical issues and demonstrates how United Way, its donors, and community partners are working together to solve those issues. Our African American Male Initiative, which was started 11 years ago, has engaged nearly 250 adults who have mentored more than 250 local kids. This program offers mentor relationships to students in Wiley Elementary, and we follow them through Jackson Middle School and Smith High School. Every other year, AAL hosts the annual speaker series where high-profile individuals share their connection to poverty and how to overcome it. These are just a few examples of AAL's community engagement. We volunteer with United Way because we are excited about United Way's focus to end generational poverty right here in Greensboro. We're excited to host today's Lunch and Learn, which will focus on the disproportionate impact COVID-19 is having on our Black and Brown communities. Addressing poverty all too often includes addressing generational inequities. We hope you will find today's program to be informative, and we hope it will inspire you to share what you've learned with others. At this time, I'd like to introduce fellow AAL cabinet member, Dr. Antonia Richberg. She will moderate.
Thank you, Carla. Hello, everyone. I'm excited to be here with you and everyone who has joined with us today. I have the privilege of moderating today's event, which will feature three people I have known for many years. Today's speakers have servant hearts of gold and immense intellectual capabilities. Together, they truly form a COVID-19 response dream team. As Carla mentioned, I am Dr. Antonia Richberg, and I have the privilege to serve as Cone Health Foundation's Vice President and Senior Program Officer. In this role, I have witnessed my colleagues at Cone Health respond to the COVID-19 pandemic in inspirational ways for nearly a full year without hesitation. Our frontline nurses, doctors, and healthcare workers are true heroes. Thanks to their tireless efforts, this community is safer, but they will be the first to tell you that there is so much more work to be done. A key component to this work is ensuring that all people receive truthful COVID-19 information and access to testing and a vaccine. Sadly, that component of the work is harder than it really should be. As Carla said, we are fighting generations of inequity and a growing culture of misinformation that fuels fear and the spread of the virus. And the truth is, there are pockets of our community that have been impacted more than others. So as a community, what can we do about this? Well, I think today's speakers will provide many answers to this question. Today, you will hear from Wanda Martin, who currently serves as a nurse in Cone Health's Congregational Nurse Program. I do want to pause and say, if you could put your phone on mute if you're not speaking so we won't hear the background noise. Thank you. Wanda is a certified faith community nurse and she used to be a clinical instructor at North Carolina A&T State University for 10 years. And she has surmounted numerous awards and honors, including being recognized as one of the top 100 greatest nurses in North Carolina. Wanda will share with us how COVID-19 has disproportionately impacted the Black and Brown community, especially those living in poverty. We will also hear from Dr. Patrick Wright. Dr. Wright is a pulmonary and critical care medicine physician with Cone Health Medical Group here in Greensboro. His practice previously included pulmonary and intensive care medicine and has recently changed to a focus on the medically underserved and uninsured populations at our local community care clinics. Dr. Wright is currently the medical director for the Congregational Nurse Program and the Cone Health Mobile Medicine Program. In collaboration with Cone Health Congregational Nursing, Dr. Wright began a medical clinic in January of last year at the Weaver House Homeless Shelter in Greensboro. He has also assisted in development of a mobile COVID-19 community screening program. Today, Dr. Wright will address myths about the virus and the vaccine. And last, but certainly not least, we will hear from Jamilla Pinder. Jamilla has been a dedicated employee of Cone Health for more than 20 years and has an extensive background working with the uninsured and underinsured residing in both Guilford and Rockingham counties. Jamilla utilizes her education and experience to help develop and support local coalitions. Through her work, Jamilla strategically partners with community-based organizations, healthcare systems, and faith-based communities to address access to care and social determinants of health, which include nutrition, transportation, and housing. Jamilla proudly takes a grassroots approach to improving public health by tackling hard to address issues at the block level. Jamilla will share with all of us what is being done to make the vaccine accessible to the communities who need it the most. So let's get started. Please join me in welcoming Wanda Martin.
Thank you for that nice introduction, and I'm privileged to be on the panel with such dedicated community healthcare workers. Thank you for your work. COVID's disproportionate impact on the community. There is definitely a link between poverty and infectious diseases. October 2020, North Carolina ranked 7th in the United States with COVID cases. Last week, sadly, we reached over 10,000 deaths. According to talkpoverty.org, in 2020, the Black poverty rate was 21.5, Hispanic 22.1%, white 9.4, Asian 7.7. 13.6% of all North Carolinians live in poverty. North Carolina ranks 40th among the states. 1 out of every 6.2 residents live in poverty. The pandemic has definitely widened that gap. The pandemic has and continues to create an economic crisis, widespread job loss, and income loss. There are some estimates that during COVID-19, the US poverty rate could reach its highest level in 50 years. Death rate from COVID-19 is about 6 times that of a typical flu season year. Yes, the pandemic has the potential to further entrench poverty rates and economic injustices. Infectious diseases like COVID-19 thrives among populations that are living in low-income communities. Blacks infected with COVID-19 are hospitalized 2.9 times the rate of whites. Latinos, 3 times the rate, and they die twice the rate of whites. There's no doubt that underserved, uninsured communities are and continue to suffer from COVID-19. This pandemic highlighted and intensified the hardships of people of color, especially those living in poverty. They have died disproportionately when compared with our white counterparts. People living in poverty each day. This pandemic has created many problems. COVID-19 didn't stop people of color living in poverty from continuing to support their families. Low-income families living in poverty continue to put themselves at risk each day by working in our essential jobs. So who are these people of color that we're referring to? Hispanics, Blacks, Native Americans, American Indians, and Asians. These people experience more serious illness and deaths caused by COVID-19. So why is this happening to people living in poverty? We look at social drivers or social determinants of health. These are places and conditions where people live, work, play. These conditions affect the health risks and outcomes. So what are some of these drivers? Discrimination in housing, educational, criminal justice, and finance. Yes, this includes racism, which leads to toxic and chronic stress. We all know that stress wears down the immunity system, which also makes us more vulnerable to infections and death. Housing. People living in poverty are facing more evictions during COVID-19. Take, for instance, a family of 7 to 8 living in a crowded 3-bedroom, 1-bath house. If one member gets COVID-19, what happens? The entire family will get COVID-19 more than likely. But in that household, those with underlying health conditions as asthma, diabetes, or respiratory problems, they get sicker. They go to the hospital and they have a higher risk of dying. This same scenario plays out for people working in our meat packing plants or our inmates in our prison systems. They can't possibly socially distance. So they're at more risk of contracting COVID-19. Food insecurity is another driver. We have all seen on TV the long lines where people have been waiting in line for food. Hours they have been waiting. Food banks are unable to keep up with the demand. COVID-19 has made the demand even harder. People lost their jobs, income has been cut short, food has soared, and they're unable to provide for their family. In 2020, North Carolina ranked 42nd in food security. And with COVID-19, it just pushed it further up. Education. When schools closed, families living in poverty or low income, many didn't have access to computers or internet access was limited. What happened? Our children were unable to learn. They lost skills in math and reading and socialization. We saw increasing numbers in mental health issues like depression, isolation, feeling of loneliness. We definitely had more suicides, and yes, domestic violence increased. We all know that when there is no job, no food for the family, it creates friction in the family, which in return causes more domestic violence. Occupation. So what jobs were impacted by COVID-19? As we struggle to put in place safety strategies to prevent the spread of COVID-19, we did not intentionally mean to harm families living in poverty, but we did. We cut the mass transportation hours. People were unable to get to their jobs. They lost their jobs. Many workers that are essential could not work from home. Their jobs did not allow that. So what were some of these jobs that were essential that people had to continue going to? Environmental service people, housekeeping, food service, restaurant, grocery store, mass transportation, home health, salon and barber operators, our prison guards. All of these services could not be worked from home. The people in the essential positions put themselves at risk each day from contracting COVID-19. and taking it home to their families. Most of these people were provided the least protective equipment, and yes, were poorly compensated. These are the people who delay seeking medical care. These are the people who appear at the emergency room sicker, needing hospitalization, and yes, most of them often die. Healthcare access and utilization is another driver. Distrust of the healthcare system is deeply rooted in our history and our culture. The pandemic also created great fear. 70% of Black Americans believe that they are treated unfairly when they appear at the emergency room or with their doctors. They feel that they aren't listened to, and they're sent home early without all the testing that could be done. And they state that they feel their pain is always ignored. Immigrants, whether they're authorized or unauthorized, are blocked from accessing public health benefits. And they feel that if they seek care, they will be deported. Systems are designed where information gets to the poorest communities last and the more affluent communities first. People living in poverty, low income, have limited ability to take off from their jobs, very little vacation time, and many do not have insurance. Some refer to this disparity as a manifestation of institutional racism. People living in poverty don't have wealth to ride out this pandemic, so they risk their lives each and every day to provide for their families. Yes, they work, they become exposed, they contract COVID-19, and many of them have died. North Carolina is a state that has not expanded Medicaid, which would allow more jobs and health care for so many people of low income and living in poverty. Without health insurance, families lack the funds they need to purchase needed medications for chronic conditions like high blood pressure, diabetes, glaucoma, heart disease, and kidney disease, and so many others. We know that if chronic conditions are not managed, the risk of contracting COVID-19 increases. You become sick and your chances of dying increase. This pandemic has clearly pointed out the need for better health care in our communities to prevent the risk and spread of disease. This pandemic has yielded levels of poverty, food insecurity, finance loss, and hardships for all Americans. But for people living in poverty, the hardship has been overwhelming. COVID-19 has offered us a time to pay attention to inequalities in healthcare. The big question is, what will we do knowing COVID-19 has shown us the disparities in health, economics, education in our communities? So I conclude by saying, we can act on these disparities or we can ignore them. We will pay a higher price if we take no action to improve the healthcare for all people. If we fail to target these healthcare disparities, our communities will not be safe because healthy residents equals a healthy community. Thank you.
Thank you, Wanda, for that informative presentation. It was quite sobering to hear about poor people facing eviction, in need of food and stable employment while dealing with this pandemic and their fears in seeking healthcare assistance. While many of us have heard from others that more people of color, particularly those living in poverty, are disproportionately impacted by COVID-19, I think hearing this today, supported by data, was alarming and disheartening, particularly since longstanding systemic health and social inequalities have put more people from racial and ethnic minority groups at increased risk of getting sick and dying from COVID-19. So this presentation really underscores the need for us to take the vaccine to not only protect ourselves, but our friends and family. So now let's hear from Dr. Patrick Wright, who will help us dispel myths associated with COVID-19 and the vaccine. Dr. Wright, take it away.
Thank you very much, Antonia. I'm so honored to be able to meet with this group today because we need your help, honestly. Another statistic that just came out yesterday is staggering. We've had the biggest drop in life expectancy in 2020 since World War II in our US population, 1 full year. Normally that's measured in decimal points. But for our community of color, it was 2.6 years. This is a crisis. I'd like to speak today about the myths surrounding the virus and the vaccine itself, and hope to be able to engage your all's help with getting this information out to our communities. How do myths start? Well, frankly, myths start on social and other media platforms. They spread extremely quickly. We had the election cycle fueled by politicians, frankly, who are not transparent and are trying to gain political points and using the pandemic for a political weapon. And it impacts individuals who have been experiencing extremely high anxiety. They begin to get lack of trust, and they're very reactive in nature, and they're sometimes very individualistic, and they spread these theories. So I'm going to speak about myths and facts around both the virus and the vaccine to you. And while I'm talking, I want everyone to have that mental image, that picture of coronavirus we've seen 1,000 times this past year and 4 months. The spherical structure with these hundreds of spike proteins growing out, because that is where and how the virus affects our body, and I'll be getting into that as well. So one of the most common virus myths was the increase in cases we saw was from more testing. Reality was it was an increased percent positivity. In Guilford County, in our last surge in January, we were up to over 18% positive. We're at a little under 10% now, not good enough. We got to get down to 5% or less. Another one is herd immunity. Let's just let folks go wild, no mask, and we'll just let the herd immunity. If we allowed herd immunity, we can look at Sweden and see how well that worked out, or maybe South Dakota. If you let folks go wild with no protection, no intervention, no public health measures, it would require 70% of our population to be sick with this virus. Think of the untold damage, magnified what Wanda just said. The number of deaths are overblown. It's just a statistic. It's misstated, incorrect. Those conspiracy theorists look at death certificates and they see the comorbid diagnoses in the death certificates. What they don't understand is the catalyst behind those deaths. These are folks that would still be with their families had they not gotten the virus and started that COVID storm spiral. The mortality rate, as we see of the statistic I just showed, and the decreased life expectancy speaks out to that. Every time I see in the New York Times famous people who died of coronavirus, notice the increased numbers of that. And then the theory that only elderly with coexisting conditions will be hospitalized. I can tell you with our last surge at Cone Health, we had a huge population between 30 and 50 years of age that got admitted, and many were deathly ill. We have had a case where athletes get the virus, very young, healthy athletes. They go home and then have a sudden stroke and pass away. I mean, these are real statistics. The quality of the data is not to be trusted. Well, I know early in the pandemic, there was a lot of confusing information, but we were just learning about the virus, and this led to skepticism. And again, politicians not being transparent with the facts sort of increased that. How about this one? Hot and cold weather will kill the virus off. Well, I think we've disproved that myth. Vaccine myths. Let's talk about that. It will cause infertility. There's absolutely no data to suggest that. So what is in the vaccine is a snippet of a protein called messenger RNA. And as you think back to your high school biology, that is a short piece of protein that's essentially a blueprint that your body has for making other proteins in your system. And in your immune system, your lymphatic system, your so-called T cells, the vaccine, when it is injected, it is not injecting live virus. It's injecting this short little segment of messenger RNA that gets into the cytoplasm of your cells and produces the antibodies that we need to fight the virus. It does not get into your nucleus. It will not cause infertility whatsoever. It was rushed. We pushed it out too fast. Believe it or not, the scientific community has been waiting for this pandemic for many years and has been planning for it. Actually, the vaccine technology has been in place for at least 3 to 5 years, and the messenger RNA ability to produce these vaccines quickly using this messenger RNA platform they've been waiting. And once China shared with us the RNA genome of the virus, it did not take long for scientists to figure out the snippet of the RNA that was the blueprint for making the spike proteins that I'll talk about that led to these breakthroughs. The other thing is they did several phases at the same time. When you do scientific research and you have time and you're not in a crisis situation, you can let phases of different research carry out for several years. We didn't have that time. So they correctly did multiple different studies at the same time. Our community of color was underrepresented. Well, actually 13% of trial participants in the AstraZeneca, Pfizer, and Moderna were from our community of color and from our Black community particularly, and that matches recent census percentages. 18 to 20% were Latinx. All the appropriate steps were taken, and it was an FDA emergency use authorization. After you get the vaccine, you're going to test positive for COVID. No, because it's not the live virus and you will not test positive. Oh, it gives an implant and puts it in you and it's going to track you. Again, another conspiracy theory that's absolutely incorrect. And also it's not made of eggs or fetal tissue. Many thought because it was being kept at such low temperatures, that was to protect some weird thing that would get into you and so folks could track you. And again, incorrect. The side effects are worse than disease. Well, look, I know young people get a stronger reaction and some people can get ill, but if you think about it from a public health perspective, safety piece, you're preventing a super spreader event and preventing the spread of the virus. And frankly, what I tell patients, it's your body building its body armor, and you need that immune response to protect you in the future. You have a grandmother you love, a parent, a sister, a brother, a cousin or someone in your congregation at your church that has an immunosuppressed condition, you're preventing from giving that to them. I can't get the vaccine if I'm pregnant. Actually, it turns out you can get the vaccine if you're pregnant. They haven't studied it in pregnancy. They're doing a trial now, and we recommend our patients confer with their obstetrics healthcare provider for that. Once I don't need the vaccine after I've had a COVID infection. Actually, that's incorrect. The immunity you get after a COVID infection does wane over time, and you need to obtain that vaccine in order to recover. And actually, we're now recommending within 2 to 3 weeks after the infection, provided you're out of your isolation, your symptoms have resolved, you can get your series of vaccines. The science behind the vaccine and the testing, again, that messenger RNA going into the messenger RNA with the vaccine going into the patient, creating that antibody response that binds to those spike proteins. And it does two things there. One, it reduces viral replication, viral load, but it also binds to the free spike proteins that get into your immune system that turns on all the immune responses that you end up seeing. As far as the testing goes, we use the PCA test. That's with the swab, and it takes a day or two to come back. That's, again, testing portions of the mRNA that picks up on that test. And then we have a rapid test, which, while not as it is sensitive, it is still valuable. If someone's symptomatic and that rapid test is positive, that really helps us a great deal in that regard. I want you to think about, in terms of the vaccine itself, it is a snippet of the messenger RNA. It encodes that portion of the spike protein, and pictorially, by binding that, it reduces the immune response. And that immune response is horrendous. It can cause multi-system organ failure. It can cause effects on your stomach, on your lungs, on your neurologic system, increase in coagulation. It has long-term effects too. And this is another thing that Wanda alluded to. We'll have significant healthcare access challenges if we don't get this under control. Even if you recover from the virus, many of the patients I see still have long-term neurologic, muscular, psychologic, pulmonary, and cardiac side effects that last many, many months after the initial illness. In terms of vaccine facts, pediatric trials are underway. We'll soon be seeing vaccine for 6 and up. You do have to wait 14 days after your vaccine to get another type of vaccine series. And the timing, again, you can get the vaccine, but you need to wait till you're fully recovered from your infection after the COVID infection itself. And then we have at Cone Health a monoclonal antibody program. And actually, we've been treating patients in the outpatient world for monoclonal antibody with significant improvement in them and reduction in hospitalization rate. If you get treated with the monoclonal antibody, you can still get the COVID vaccine, but you need to wait about 90 days afterwards. We're now vaccinating healthcare workers over 65, long-term care, but starting February 24th, teachers. And Jamilla is going to be talking about how we're going to ramp up that strategy into our community as our vaccine supplies do grow. We are able to vaccinate also lactating individuals as well. The side effects that you're seeing that people get, that is your immune response, whether it's the headache, the muscle ache, the arthralgias, that is your body building up the immune system. There are allergic reactions. It's usually to some substrates that go into the vaccine, polysorbate, polyethylene glycol. They're very, very rare. We watch for that on site, and of course have medications to treat that. And then that's my comments regarding that. I'd like to talk just very quickly to end my time on how we can engage our community and how we need your help. Strategies that I have seen effective in my practice. I try to connect with my patients. I try to use analogies. I try to get to know the patient. I try to actively listen to the patient. I try to find out what their fears are. Is it the fear of needles? Is the fear of previous experimentation in that community of population? What are their concerns? Do they have conspiracy theories? I think we need to improve our communication methods. The concerns on vaccine safety, they need to be acknowledged. They need to be carefully explained, what I've just explained. Social norms will influence vaccine hesitancy, and our community of color has this history of mistrust anyway because of prior unethical public health research in the Black population. We need to be transparent and thoughtful with our communities, and you as community leaders need to partner with us. It would be great to partner together. We need to partner together and having sessions like today to share these ideas. So to finish with my remarks, I would say our steps are we need to acknowledge the past and the past injustices. This is a safe space. We need to engage, like we are today, influential community, religious, and grassroots leaders to help with messaging. We need to go to our congregations and other community areas for this. We need to have intentional, effective communication with community partners like yourselves. And then, as Cone Health is now doing, we need to partner with state and local agencies to reach out to these underserved populations, improve access, as Jamilla is going to speak to, connect with our populations with multiple modalities, not just computers. Some of our folks are shut in. They don't have access to technology. Maybe it's telephone calls, knocking on the door. We've got to reach out to folks that are locked in and cannot come out for vaccines. We have to identify what their concerns are and address them and prepare to address the vaccine myths as I have today. We all need to collaborate. And finally, we have to focus on, frankly, this is a civic responsibility. I mean, to think that we have lost 2.6 years off the life expectancy of our Black population in 1 year, when normally these things move in 0.1, 0.2, and frankly, in the other direction. We've been increasing life expectancy. In 1 year, we've managed to remove 2.6 years of our community of color's life expectancy. That is simply unjust and not uncalled for. This is why we have to get together and all of us work together to push forward this vaccine strategy. Thank you for allowing me to make my remarks.
Thank you, Dr. Wright. Wow. I don't know about you guys, but that was a lot. And really, really sobering. Dr. Wright, we just want to thank you for dispelling the myths and sharing with us all the facts about COVID-19. You really enlightened us on the reality that there's a lot of misinformation about COVID-19, and it's important for all of us to make sure we know the facts. So now let's hear from Jamilla Pinder, who will let us know what's being done to get the vaccine into the communities who need it the most. You're up, Jamilla.
Thank you. It's kind of hard to follow Wanda and Dr. Wright, but I will lead with 3 points. Community is the table, not bring them to our table. How can they reach us? And visibility leads to credibility, that leads to sustainability. And that's exactly the approach that we're looking at, because like Dr. Wright just spoke about, are we maintaining systems that are actively harming people? And when you think about that, are we maintaining these systems? And one of the things that we have started to do with looking at where we need to show up and where we need to be to make sure the vaccine is accessible is using our analytics team to use the analytics data that we have to make sure we're showing up in the right areas. But in addition to that, using our observational and our live learn experience to determine where do we really need to be showing up. I'm just going to show a couple of slides to visually show you where we are at Cone Health and with some of our partners to make sure that we are meeting the needs of the people where they are. Hopefully you can see the screen. So just to provide some background as where are we, how are we showing up and where we need to be. We started with the SVI. I'm not sure if you're familiar with the SVI, but it's the CDC Social Vulnerability Index. And what that does is it takes census tract information to be able to, and it rates it, indicating where you have higher rates in terms of increased vulnerability. So as you see, there's 4 different components that build up this SVI index, which is socioeconomic status, which Ms. Wanda was able to outline just depending on the areas that we have. So that's everything from your income to your jobs, things of that nature. Then we have the household composition. So who is in the household? Where are you living? How many people are living in the households? Is it single family homes? Is it multi-families living in an area? Then looking at the minority status. So looking at the areas in terms of how many people live in a certain concentrated area, and then looking at the housing type and looking at transportation. So do you happen to have a car? Do you happen to be close to a bus line? And so when you look at all of those things, they're able to come up with that social vulnerability index. And based off of that, it allows us, again, like I said, using our analytical data to be able to determine what our observational data has already given us to show where we need to be. So right now, when you're looking at what we've been able to do in the community, you can see we have our Guilford County slides. And if you look at the 2 maps that I have here, one map on the right-hand side shows the SVI data. And then the other map on the left-hand side shows where you have the highest vulnerability rates in our city. So if you look in the shaded area where you see the yellow, on the, we'll start on the right-hand side, where the yellow is the yellow, where you see the deep yellow is where we have a higher social vulnerability rate. Over here on the left-hand side, you're able to see where we have individuals that we know of within our system where we're tracking the data that has received the vaccine right now, 65 and older. So if you look at the dots, it's the purple dots that you have right here. These are the areas in which we have already been able to partner with community members, faith-based organizations. Within our organization, we have the Congregational Nurses Program that are nurses that are working in local churches to provide health and wellness, to be able to say, okay, where do we need to show up? What do we need to be doing? And so what we started with our vaccine, because we have the fixed site, of course, at the at the Coliseum, but really started to see where do we need to show up based off of the input that the community has been giving us. And so based off of that information, we partnered with a physician office. We partnered with 3 other churches to be able to say in the areas where you see the heavily highlighted areas, and the heavily highlighted yellow areas are actually off of, it's the east and west part of the city. So it's your Gate City Boulevard, it's your East Market Street, all of that's in that area right there. So we were able to partner through our partnerships that we have with True Salvation Church, which is off of Spencer Street, which is off of English Street. We partnered with East Market Street, Seventh-day Adventist Church. And we also partnered with New Zion Missionary Baptist Church off of MLK, because again, these areas based off of the SVI index showed us that's where we have the highest vulnerability rates in our city. So we started there where we partnered with the churches to say, hey, would you be willing to be a host site? And as a host site, you would allow us to partner with you to work with your congregation and work with members in the community to be able to, again, meet the needs in the community where people live. And how we partnered with them was we said, hey, we know that digital access is a challenge because not many people have an opportunity to be able to go online. You might not have access to online, you might not have access to the computer, or if you do have access to the computer, you might have challenges with being able to go in and schedule an appointment. Then we heard many comments from the community about the phone call. Whenever I try to make a phone call, I either stay on hold for a long period of time or hang up. So looking at some of that feedback that we received from the community, we said, okay, what is it that we can do to kind of eliminate some of those barriers and not create more barriers? And so with those churches, what we partnered with them we gave them a spreadsheet and just said, hey, we have 100 vaccines. We would like to start with anybody that happens to be within the community, in your community-based organization, be in your church, or within a 1 to 3 mile radius of where your church is, to say, hey, we have 100 vaccines. What you need to do is just get your name on the list. And then at that point, they would be called and reminded and told what time their appointment is. And so what we did was we got the list back from the church as a partner. We got the list back from the church. We then on our end, because again, it's all about how can we reduce those barriers. We went in and scheduled those appointments so that when individuals came up to the site to receive their vaccine, all they had to do was to give their name. We were able to register them and give them their second appointment. By cutting out so many different pieces and then also working in the community where there's trusted partners, it allowed us to be able to show up in 4 different areas to be able to provide that vaccine. Since this slide, we actually have more sites that we've been at since then. But again, the value of community and the value of those trusted partners and places in the community. So the fact that we partner with the congregational nurses who are already trusted members in the community and trusted members in some of the churches, as well as some of the other organizations that work with our refugee and immigrant groups, proved to be successful with being able to do this. And so it's easier for using non-traditional methods, so to speak. It's easier for us to say, I'm going to call Miss Wanda that's at such and such church, and then that person calls that person, kind of like an underground method, to then be able to get on the list and then to find out like, well, that was easy, and then to be able to show up and get the vaccine. So using those approaches and not necessarily having people to go online or get on the phone call and talk to someone else to try to get that appointment. It was just easier to get it from that trusted member of the community. And to go back to what Dr. Wright said, we need you. We need you as your faith-based organization. We need you as your community-based organization to be our ambassadors, to work alongside with us and say, hey, this is how we are able to get you the vaccine. Because a lot of times we look at how do we reach people? Well, the question is how can people reach us? Many of us have the resources and the access to be able to call up somebody and say, we need this. But with most of the people that we're dealing with that fall within this SVI index that have limited access to transportation, medical care, and other social resources, don't have that same luxury to call this person, and then they're just left with just this perpetual state of lack. And so with this method, we found that it has been very helpful, and more people as a result of this, we've been able to get more and more churches, other civic groups saying, you know what, I want to be a host site. I want to be able to work with you. And as that host site, they have that connection with the community as well as the members. And so using this
I think we may have lost Jamilla for a bit here.
Okay. Well,
Carla or Antonia.
yes, I'm so sorry that we're having technical difficulties, but we want to honor your time, so we'll go forward, and we want to thank Jamilla for the information that she shared on COVID-19 testing and vaccinations. I think what really resonated with me was the CDC's Social Vulnerability Index and this impact on COVID-19. Just to know that there's now an index out there that gives us, that takes that informational data that's needed to show how poverty, lack of access to transportation, and crowded housing may actually weaken a community's ability to prevent human suffering and financial loss during this pandemic. I mean, imagine that, guys. Poverty really has an impact, something that most of us know, but a good way to show that in a factual aspect. This dream team did not disappoint us today. They shared a wealth of COVID-19 information. Wanda, Dr. Wright, and Jamilla, I want to thank each of you for this important information that you've shared today. I've learned so much, and I hope those who joined us have as well. And thank you for all that you're doing in this community. Your service is an inspiration to all of us. Now we'd like to hear from our audience and give you a chance to ask questions. We have exactly 12 minutes left, and I have a number of questions, but in fairness to you, I want to give you an opportunity to ask questions. And then if you're shy, then I'll interject my questions. But I do want to give you an opportunity to ask first. You can either submit them in the chat or feel free to unmute yourself and speak up. And we'll have time for a few of those questions. And I'm trying to multitask here to see if we have questions in the chat. And I don't see any at the moment. And Carla's going to check behind me just in case that some come up. But while we're waiting,
can I ask a question then, since there's not a first question yet? So Dr. Wright, I think those of us who are parents and those of us, well, I'm not one of them, who are between the ages of 18 and 35-ish and who are in childbearing years, there's just such a big question mark. And I appreciate your comments around the way the vaccine, just the composition of the vaccine. It doesn't necessarily go into a woman's reproductive system. We also know that they probably didn't do any testing on pregnant women, correct?
That's correct. They are supposedly doing a trial now in England, I think, but there is not current data. So what we do is we have the women meet with their obstetrician. We have had some get vaccinated. Some have decided to wait, but there's no scientific data to think that it would cause a problem. Same thing with lactation. The way I think about the vaccine, when it goes in, it's a small snippet of messenger RNA. Your body's immune system, they're called T cells, immediately it connects with your immune system. It doesn't flow throughout the entire body, if you will. It goes straight into the immune system and is processed in the immune system. So it's, and then by that, you start producing antibodies. Because the cells, if you remember from high school biology, it doesn't go in your nucleus. Remember the endoplasmic reticulum? Remember the little science cell, with the cytoplasm? It's right up against the nucleus. These things called ribosomes. Are we shaking some memories of high school biology? But you get in there and that is absorbed and goes straight to those ribosomes. And it's a blueprint. It's a production blueprint for how to produce protein. So in that respect, scientifically, it should not, and it does not get into the nucleus. So it will not enter ova or sperm cells to alter the nuclear aspects. And it should not, if the individual gets a reaction, whether it's, some soreness, et cetera, it's an immune reaction, it should not be harmful to the baby. Now, having said that, no, trials weren't done, and they're looking at trials now. And I just think it's why I always say you have to consult with your healthcare provider about whether you should or should not receive the vaccine, or maybe delay till after your pregnancy.
Thank you very much.
Thank you, Dr. Wright. So we have a couple of questions. One question was whether or not we were going to send a link of to the recording. And my understanding is that United Way will have that on its website within an hour or so after we have completed this session today. Is that correct, Michael? I think that's correct. If not, I will let you know.
We'll send an email follow-up to everyone on the call today with a link as soon as we can.
Okay, so as soon as we can, we'll get that out. Give us a chance. We will definitely get that to you. And in terms of those who are wanting to seek Dr. Wright to speak, Linda, you can contact Dr. Wright offline, and I'm sure he'll let you know if he's available to speak to your group of African-American women. He certainly has a wealth of information.
Yeah, I'll throw this out. I told Michael, I'm more than happy to speak to any of the other groups, and so we can set up future meetings with your groups. My email address they'll share, and I'm happy to do that. One more quick thing before I know we got to sign off. The variants, a lot of scariness around the variants, particularly the current UK version, which is called B1.1.7. The deal with it is there's small mutations in that spike protein that allows that virus to stick onto your respiratory tract and hold and get inside your cells, start dividing and replicating, and then the darn thing explodes out into your respiratory tract. I've seen electron micrographs. There's millions of these little virus particles all up and down your respiratory cilia. It's very, very kind of a shocking picture. Well, the thing is, we don't know yet lethality. We know very contagious. We don't know yet lethality. However, here's the good news. It feels like the vaccine has enough efficacy so far to attach to enough of that spike protein that's been slightly altered in about 3 places. It looks like a big piece of cauliflower or broccoli if you look at it on electron microscopy, and it'll stick enough to that to keep that viral load down. That's the key, is your viral load. That's why the monoclonal antibody helps you, because it reduces your viral load. So that's the key. Now, right now, you know, viruses mutate all the time. The flu mutates, common cold mutates. What happens is they make mistakes when they're doing on that ribosome, making that copy of new antibodies and new viruses. They make mistakes, and the virus has new genetic sequencing, et cetera. That's how it happens. So we don't know yet on these new variants. We'll have to see. We think, if anything else, it will at least reduce the severity of the illness. It may not completely keep you from getting sick, but hopefully not wind up in the hospital, in the ICU, on a ventilator machine, multi-organ failure, COVID storm, blood clots everywhere, strokes, debilitation, chronic fatigue syndrome. We hope we'll have a reducive impact. Imagine the burden on our healthcare system and our communities who are underserved cannot access care now, and then they have all these other new problems to deal with that Wanda mentioned. This is why we've got to get on this and get this vaccine. The sooner we get this vaccine out, the less of these variants we're going to have to deal with. So that's what I say about the vaccine variants. I mean, the virus variants.
So Dr. Wright, while you're speaking, I'll ask you one additional question that's come from one of our folks that are on the call today. What about those folks that are HIV positive? When will they be able to get the vaccine?
They're in the next group, in the high risk group. They're about to go, after we get through the teachers and the frontline essential workers, et cetera. The very next group are folks less than 65 who have comorbid conditions, and anybody immunosuppressed should get it. It will not affect whether you're HIV active or whether your disease is under control. All those groups should absolutely get that. Here's a positive thing to think about. If we can get, this is why our work together and collaborating is so incredible. I mean, you guys are saving lives. You guys are going to save lives by joining our fight. Just think about it. You're no different from the doctors and nurses working in the hospital. Your work and your community groups and your churches and other organizations will help to save lives. If we can get 70% of our population vaccinated by late 2020, by late 21, you know, we will really be seeing us turn around the corner on this. And it reminds me of the 1919 Spanish flu epidemic. It took 2 years, and that's without vaccines in 1919. This is the same thing, except now we have a powerful tool. We just need to partner together to get that out to our communities and help dispel these myths.
Okay, so.
And Antonia, I wanted to add to that the importance of that partnership, because it's through that education piece of it, and then concurrently working with the outreach piece of it is what's going to help, because we have a large population of individuals that are still hesitant and don't really truly understand what this is. And it's not hesitancy with the system, but hesitancy with the virus, but then also equipping them with the education. So as you go back to your respective organizations and faith-based communities, and even within your community for that matter, to be able to say, what does it look like to be ambassador? How can we give you the resources and tools to be able to speak to this, and then be able to do the follow-up and say, like someone mentioned, oh, well, Dr. Wright, can you come to our team? And that's one of the things that we've been doing, is making sure that we're having town halls with our providers, having town halls with our local hairstylists and barbers, as well as working with other groups to say, hey, I want to sign up and be an ambassador. I want the information so that we can equip you to be able to go out and have these same conversations, and to bring somebody from the healthcare profession along with you to be able to provide this. because we're not only, like we mentioned, this is the disparities with amongst our Black and Brown communities, making sure that we're doing this in Arabic, making sure we're working with our Bhutanese and Burmese population, making sure we're doing this with our Latinx community. And that's a lot of, I feel like I've been going on a tour, but it's important to be able to bring that layperson and also with that healthcare provider to be able to come in and create these spaces where we're able to do that. And then when you're talking about access, being mindful that we're looking at how are we going to make sure we're providing this information and these resources, as well as the vaccine, during times where it's accessible for people. So is it in the evenings? Is it on the weekends? So making sure we're keeping that in mind as we're educating people, doing the outreach, and then making sure the vaccine is accessible. Sorry.
Okay. Thank you. Thank you. So we have a couple of minutes left, and I want to transition back over to the chair of AAL. But before I do that, I do want to say that the question came up, can those 65 with cancer get vaccinated now?
Yeah.
Under
Yes.
65, under 65 with cancer.
Under 65.
The next phase.
That's with the next phase. I think it'll come soon, though. I mean, right now it's 65 and older, but those under 65 with immunosuppressed states, HIV, cancer, et cetera, that's coming up real soon.
Right.
It's going to start really rolling out.
And Jamilla, if you answer the two questions that are directly to you in terms of your email and the one pager, then we can have those questions answered. And so as we transition over, just want to let you guys know, those that are still fearful about taking the vaccine, I've taken it. I've done the first one and the second. I had the second dose yesterday. So for those of you all think you're going to get the second dose and then you're just going to be feeling really terrible, I normally feel horrible after every shot because I'm so adverse to shots. But at any rate, I feel great. So just so that someone it's been less than 24 hours since I had my second dose. So just to let you know.
Dr. Wright,
question.
Yeah, Dr. Wright, will you also send so that we can send it with the video to everyone on this call, the timeline for groups? Because there's too much back and forth.
There is, yeah. I'll send something to Michael and get that out with the link.
Thank you.
Michelle. Yes, ma'am.
Appreciate that.
Okay, I'll turn it over to Carla. Thank you all so much.
Thank you, Antonia. Thank you so much to our panelists. A collective round of applause. I'm going to just say everybody's applauding right now. Thank you. This was certainly informative, very necessary information and conversations that we have to continue having. We are so grateful to be able to bring this information to those communities who need to know it the most. Again, it's obvious we have a lot of work to do because those numbers were staggering. It's quite upsetting to hear how we and I know I feel motivated just knowing that we're on the mark, we're having the discussion, we're talking about it, and African American leadership is committed to joining and being part of this fight. Again, as we mentioned earlier, do look for the follow-up email that will be coming to you. It will include a link to today's recording. Please share that with anyone who you know who could also join us in this mission, but also those who wanted to attend and maybe they're out of power and just couldn't log on. Together as a community, we can combat COVID-19. In closing, much thanks to United Way of Greater Greensboro for all the efforts and partnerships to ending poverty in our community, but also recognizing that in order to end poverty, we must address the inequities in our communities of color. Thank you again. We are just a minute over. I want you to stay safe, stay warm, and have a great day. Thank you for joining us.